This is Michael Smith from the Real Talk School of Nursing podcast. Nursing school is a struggle for many. Everyone struggles at one point or another, even that seemingly bulletproof student you're thinking about right now. Some people will struggle with tests, some will struggle with clinicals or lab or sims, and some of those students who struggle with none of those things will struggle within the profession. Nursing school is a struggle for some from day one until the day you graduate. It was for me. It might be for you too. But trust me, if I can make it, you can. Just keep working hard. Be truthful to yourself. Be joyful in the hard stuff. On the other end of school is a profession that is amazingly hard. I'm not going to lie to you, especially in the first year. And the rewards, though amazing, are sometimes heartbreaking too. You will have to wade through a lot of muck and mud to get to these amazing little jewels of experiences that make coming to work worth it. Nursing and nursing school isn't just about learning content, about learning the tasks that you have to do. It's about learning to grow through adversity, coming out the other end stronger. You will struggle outside of school too, but I promise you when you make it, it's worth it. So I'll see you on the other end of this crazy nursing school journey. Welcome to the Real Talk School of Nursing podcast, Season 4, Episode 19. I'm your good and faithful host, Michael Smith. Today, we're going to talk to Nurse Allie. You'll find her page on Instagram at gravel_walknurse and look up and subscribe to her YouTube channel by searching for Nurse Allie. She's a hospice nurse, and I wanted to bring her on because I think she has a great attitude and works in an area that not many new grad nurses consider. So let's learn a little bit about her and her experiences and just see where it goes from there. Thanks for joining me. Let's jump right in. All right, well, welcome, Nurse Allie.
Hi, how are you?
I'm doing so good. I'm so glad that we were able to get together today. We had kind of a rough go trying to get together, but it finally happened. So I totally forgive you for your desire to wear capes again.
Oh yeah. Well, I'm still bringing them back. I think it's going to be a thing.
If you don't follow me on Instagram, first of all, you should. But after you follow Gravel Walk Nurse or Nurse Allie on Instagram, you should definitely follow me. But you should definitely follow her first. But it started, I don't know, like a week or two ago or something like that. During the what's the scrub company called?
Oh, the figs.
Yeah, the figs
thing. Yeah.
So what happened was that they played a commercial that was, offensive to some people, and then Nurse Allie had this really funny post about, it was like, everybody's out there like, trying to find a new scrub company, and I'm out here trying to bring back capes. And we went back and forth the whole day, just like, no capes, no capes. And it was really funny because there was a lot of people who got it, slid into the DMs and are like, why are you so pissed at this other person?
Are you guys really mad at each other? I'm like, no, it's called satire. Get with it.
Oh, I showed, when I showed other people what was going on and just went back and forth, and they were just like, oh my God. And then I hope that you got a lot of my followers to follow you through that. I
think I did
hope there was
gain
some traffic.
And I also recruited some people who are going to bring back capes with me as well. I think I've got some people on board. The guys they'll get cloaks. How's that? You guys can get cloaks. You can be like vampires.
I'm already too pale being a night shifter. I don't need.
It'll work perfectly.
Oh God. Okay, so why don't you tell me about tell me about yourself. Tell me about your career. Like, how long have you been a nurse? What areas have you worked in? Like, tell me a little bit about your nursing journey after graduation.
So I've only been a nurse for like 7 years, a little over
That's it,
7
just
years.
7.
I know. I feel like it's not a lot because every nurse I run into, I've been like, they've been in the game for like a decade or more. And I've only worked in 2 areas. My first job was as a new grad. Usually you don't have that many choices. So it's either like nursing home or a couple of my friends actually were applying to prison. So I was like, you know what? I guess I'll apply to the prison. And I got a job at one of the state prisons. So that was my first job as a nurse, was working at a prison.
All 75 pounds of you going into a
Yeah.
prison. Fantastic.
Yeah, it was I don't know exactly what I was thinking because the nursing home scared me because their patient to nurse ratio is very high.
Yeah.
And
Did you just did you have your associates at that point?
right.
Okay.
Yeah.
Okay.
So yeah. So that's kind of
So
it.
you started off in a state prison. Like,
Yeah.
gosh, what was that like?
Well,
How long did you stay there?
I stayed there for 2 years before I ended up getting a job in hospice. And I mean, it was kind of intimidating at first, obviously. There's a lot of rules, and it is a different environment to provide medical care in.
Mm-hmm.
You kind of work with the bare bones stuff because there's not a lot that we can have in a prison environment for safety purposes.
Sure.
And it's a lot of mental health. All of that stuff. Yeah, it was different, but you learn a lot because there's you learn meds like the back of your hand. So, because everyone has a lot.
Everybody has a lot when they come in.
Yeah, they have a lot going on, a lot of different disease processes working, and it's kind of like sometimes a mini ER because there's obviously traumas that do happen within
Sure.
the prison community, but a lot of it, like I said, it's a lot of mental health that goes on in the prison with those guys for sure.
Were you operating under a doc, or were you like more or less independent and had like some, processes that were kind of written out for you? Like you could do these things, without a doc ordering it or whatever, and you had to use your own judgment. Like, how did that work?
We had a book of orders that were like preset orders, kind of like EMTs or EMS has.
Yeah.
That we do for like, if somebody had allergies or pain or whatever. But we do.
Sure.
We had a medical director. I think we had 2 or 3 NPs that actually worked there as well.
Okay.
But I worked evening, so they were there during the day. So when we came in, it was kind of just like we're kind of on our own. I mean, we always had somebody on call, but you're kind of on your own after that. So we had things we could do, but I mean, a lot of the times, like I said, if something major happened, we would just end up sending them out, but that didn't happen too often. Luckily.
So what brought you to hospice? Was it just that seemed like a good opportunity, or was it more like I got to get out of prison?
A little bit of both. So, yeah, I mean, hospice kind of drew me, especially after my grandmother passed. She passed away from her second stroke, and she was in the ICU. She had her power of attorney, but she didn't have her advanced directives in place as to what she wanted to happen at end of life.
That's a very important lesson for our listeners, is to, if you're in nursing school or you are a nurse and you're a new grad, like go and get advanced directives. Go get that. I mean, everybody should know. Oh my gosh.
Yeah,
Sure.
It's hard seeing the forced breathing from the ventilator that she was on. And she was in her 80s. So it was pretty, I mean, that image is kind of stuck into my head. And at that time I wasn't in nursing school. I think I was about 19 years old. And in my mind, I was like, there has to be an easier way. And so
there's got to be something better than this.
Right. So when I got into nursing school, my first patient, when we were still doing like bed baths and things like that, like when we were on that segment, she was a hospice patient. So like I got to witness her from pretty much the start of when she was still able to self-feed, all the way till I think the last day I was supposed to have her. I asked, "Oh, how is she doing?" And she had passed away, I guess, like minutes before I had asked them. So I got to do postmortem care and things like that. And for me, it was very much so like a blessing to be there and see that process play out and how peaceful it was to see that. Oh, not my grandmother, my patient. No, yeah.
Oh, I was like, oh my God, you had a clinical at the place where your grandma. Okay,
No way.
sorry.
No way.
Okay, I was like, wait a minute. I thought you were before nursing school. I was like, oh my God, no way.
Although people do, some patients' families do partake in postmortem care. Depending.
Yeah, that's a heavy nope.
Yeah,
that's a heavy nope.
I mean, some of it I can see not wanting to do, but other things like, doing mouth care and stuff like that.
Sure.
Maybe.
Yeah, no. Yeah, that kind of stuff makes sense to me and seems like, we're this person's family. I mean, all that kind of fun stuff.
Yeah.
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 So oh my gosh, like I remember my first patient death when I was in nursing school. And I was really mad about it because the family had been fighting back and forth. One daughter who lived out of state.
Oh yeah.
And not just out of state, but like literally across the country, out of state. Flew in, was there for 24 hours, got a POA, flew back, and then didn't allow the hospital to talk to the daughter who lived in town.
Why?
and wouldn't let the daughter even see the father.
Oh my God.
And from my perspective, the one who lived locally was totally reasonable, and and so they were just fighting back and forth, and because of this, so I had morning clinicals, and then on the fourth day we came in the afternoon instead of in the morning, and literally like 20 minutes before I got there, the patient died. And it was like right between rounds and stuff like that. And so this patient that I had been taking care of for like 4 days, which is nothing in, the med surg world, but like 4 days. And this patient died alone because the daughters couldn't figure this out between them. And it was just...
It's like children in a divorce, you know what I mean?
Oh, it was
you have to
awful.
do what's best for the person, not necessarily what's best for your ego at the time.
True. And it was like...
a lot of egos.
That was like a really traumatic event. And it... I mean, it was like... That heavily affected me. I was just like, that is awful. Like, I will never do that. I will never let that happen.
I mean, families need to really try their best to pull it together for their loved one when it comes to...
But having a plan.
And having a plan in place is helpful. But things do change, too, at the end of life. Like,
sure.
People's opinions on what they want to happen. Sometimes the healthcare proxy ends up reversing track and just says, I don't want comfort care anymore. And the rest of the family is just kind of like, why are we going to put our loved one through this? But everyone else's hands are tied because the healthcare proxy has that power to make the decision. So it's unfortunate that someone you put your faith into, even at that point, might end up changing their mind when it comes to your life decisions later on.
Right. So, I mean,
advocate.
I think it would be so easy. I mean, given that experience and then experiences I've had, obviously, as a nurse in an ER where,
that's traumatic stuff. Yeah.
Death happens.
Yeah.
But what kinds of experiences kind of keep you going? If I can stand on a soapbox for a minute, like the hard part that I've experienced as an ER nurse hasn't been death. The hard part is all of the traumatic stuff that we do leads up to it.
Right.
It's just like, we're gonna do what?
Yeah.
And again, probably because family didn't have a discussion, family didn't have a plan. Like there's nothing set in sandstone.
Right. Exactly.
But there was none of that stuff. So what kinds of experiences kind of keep you going and keep you motivated? I mean, you've been in hospice for 5 years now.
Mm-hmm. Yeah.
It seems like it's a long time and it's a lot to bear. So what kinds of things kind of keep you going?
I guess it's just the fact that I know my patient's always going to be okay in the end, even though our end goal is death. I shouldn't say it's a goal, but it's the expected outcome of when you are on hospice. So for us, we don't see any of that trauma. I've been in the room where several patients have passed away while I've been there, and the breathing just goes out so easy. It's almost like you have to stare at them for like about a minute or more before you're just like, when to go tell the family. I mean, you obviously have to listen to the heart for that full minute. But you have to it's so peaceful, and it's nice to know that patients also get to choose when they get to go home. What I call going home, meaning passing away, because a lot of people don't get that choice. So I just love having interactions with my patients and their families and being able to prepare people for that moment when it comes, so that they're more, versus like what you guys experience is just like, nobody's really prepared for what happens at all. And we get to spend maybe months, sometimes a year, depending on how long our patients actually stay on service for. And those are things that kind of keep me going. I've had a lot of great relationships I form with patients and their families, and I've met a lot of amazing people. So many amazing people.
So when I think of hospice, I think about how, somebody being on hospice for 6 months or something like that. Obviously people can
research past that. Yeah. On average.
So they can go longer, but
can.
Like, so what's, because I always get confused by this. So what's the difference between comfort care, palliative care, and hospice?
So I'm not sure. I think comfort care can go hand in hand with either palliative or hospice, but palliative, you can still seek curative treatment for your disease, versus hospice, you're agreeing to not seek curative treatment for your primary diagnosis, whether that be cancer or whatever it is. It doesn't mean we don't treat. We treat for acute things all the time. We will still continue to treat your high blood pressure, all of this stuff. We just aren't going to go get chemo. We do palliative chemo for our patients if they really, really need it as well. But that's the main difference between palliative is pain. It's geared towards pain management while you're still seeking curative treatments. Versus hospice, you have to have a 6-month or less prognosis from your primary care physician and our hospice medical director, certifying that you have that much time left. On average, hospice patients tend to live about 21 days past their prognosis because of the increased amount of care, and everything is so in tune to them. But yeah, that's pretty much the gist of it. I think we're only really hospice up until when they start transitioning. What people don't realize before that, we end up being more so like home health. We do wound care, we do med rec, we do all of these things that most home health do. But when it comes to like I said, the end goal, it's a little bit different.
Or at least the expected outcome. The
expected outcome is a little bit different. Yeah. Than home health.
Let's take a break there, and then when we come back, we'll talk about like attributes that have helped you be successful within your role, and then how they might differ from other roles that nurses might encounter. So when we come back, we'll talk more with Nurse Allie, and we'll see you in a minute. And of course, we have to pay those bills. So to help us with our sponsorship for this segment is none other than Andrew Heaton of the Political Orphanage and of Alienating the Audience. Our sponsor for today is
Snuffy's off Route 44. Snuffy's is a truly outstanding American diner with a wide range of well-priced food for the whole family, made all the more enjoyable by the fact that every waiter and waitress takes your order and delivers it to you on horseback. Yes, imagine the delight your family will experience as they ask for scrambled eggs and freshly squeezed Florida orange juice from a man wearing an apron seated on top of a horse. If you've ever been to Sonic and you've seen one of those high school cheerleaders delivering malts and on roller skates and you thought, wow, that's impressive. Well, you will be filled with rage at what a gullible yokel you were for having been impressed by such a paltry feat of locution when compared to the grandeur and the majesty of a waiter or waitress riding through a diner on a horse. Plus, if you go to Snuffy's on Tuesday nights, tell them that you listen to this podcast. They'll give you 30% off the meatloaf special. That's a humdinger of a deal right there. That's money you can put into a 529 college savings plan, or if you don't have children like me, into a 401k. Snuffy's off Route 44, because everything tastes better from a horse.
To hear more from Andrew Heaton, you can search him out on basically every platform there is out there by searching for @Mighty Heaton. That's Heaton. Mighty Heaton. Let's get back to the show. So, welcome back. So, let's talk about what kind of attributes a hospice nurse might need or be successful with that may differ from like a floor nurse or an ER nurse or an ICU nurse. So what kinds of things do you see successful hospice nurses like you might have? Like, what kinds of things do you kind of see in yourself that kind of helps you be successful?
You kind of have to be a MacGyver of sorts, because
I do like MacGyver.
Yeah, well, a lot of people do. And that's kind of like a job, because when you walk into a house, you might run into an issue that wasn't there before, or that, obviously sometimes patients run out of supplies, things like that. You have to be ready for, or even come up with things that like a temporary dressing. We don't have a stock room in our trunks necessarily as big as the ones that they have in hospitals. So you have to
like the uncontrolled environment of a home, and I'm sure you've seen everything from like squalor to like everything, right?
Huge houses, yeah. So that's another thing, is you have to be kind of like, state wants you to do certain things a certain way when you're in the home. Like we have to have a barrier between our bag and a barrier between anything of ours that touches the patient's anything. But sometimes you don't even have a place to put your bag down. So sometimes you're doing all patient care with your bag on your back, because you just can't put it down anywhere in the home. So you have to kind of roll with it, and you have to be good at rolling with things. Cause like when I start my day, I get a preliminary schedule the night before, but when I go to check it the next morning, it's already changed, and it will change throughout the day. I'll get more patients added on, some taken away because people pass away or things happen. And yeah, you have to be flexible, in that way. And you also, I know hospital nurses have great assessment skills, but we don't have a team there with us to even give us a second set of eyes on things.
That is such that is such an important part of my job, or an important aspect of the ER is that it's me and a doc. Or me and a provider who both kind of get different things, because a lot of times I'll literally like do my assessment. I'm in there with the patient, and they're telling me all this kind of stuff, and then I'll be still sitting there, because sometimes it's really nice to have both me and the doc in there at the same time, so we're hearing the same thing.
Yeah.
For some patients, and then the doc will come in and be like, well, let me ask you this question. I'm like, I already asked that. And then they will give like
completely different
a completely different answer. And I'm like, you just said 3 seconds ago. No, like,
yeah, that's the hardest part, is you have to have good assessment skills, because you're going to be the one calling, whether it be their primary care physician or one of our hospice docs or NPs or PAs about the issue.
Sure.
So you have to, and I know every time I call a physician about something, they always ask a question I'm not prepared for. I'll have my soap note done. Like, I think I hit all the marks. Like, I got it all. And then they're going to ask me something. I'm like, hold on, I got to go back in. Like, I gotta go ask them that question. So that's another thing. Yeah.
Can I ask about like how it, well, maybe I'll ask it later, but like I every once in a while I'm faced with a situation where I've got the patient telling me one thing, but then I've got a family member there going, that is complete no, absolutely not. Like two different stories, two different motivations, two different, like I have to assume that that's like a huge part of your job.
Yeah, because we do talk a lot with the families, especially with our patients who aren't cognitively our dementia, Alzheimer's patients.
Sure.
So the families are a huge part of it.
I have such a hard time with the dementia patients because it's oh my
hard.
Gosh. Yeah,
because
it's really
hard. They're not usually great self-reporters, but
at a minimum.
yeah, they're not usually great, but some of them will have like lucid moments, and they seem like they can report well, but often you have to look for those signs in our dementia and Alzheimer's patients that they're telling you something is wrong.
Yeah.
Like, you know what I mean? For some people, it may be restlessness towards end of life, and people associate that with pain or anxiety. But also, they have to keep in mind all the meds that we utilize at end of life cause urinary retention. So, like, we always have to check our patient's output because families assume that they're supposed to have like minimal to no output when it comes to end of life, but there should still be something there. So,
right.
I mean, do we have a full bladder going on? Is that why maybe they're restless? So yeah, we do have to kind of go in between patients and their families to kind of determine the best line of care. And honestly, because the doc or the provider has a higher pay grade than I do, I honestly sometimes I'll go to the hospice side of it because they're more in tune with what we're going towards. Sometimes the primary care is just like, I don't want to deal with it.
Yeah, I get that too. Too.
They're like, I don't want to. No, that's not. I mean, we usually don't go to them for hospice issues anyway. But I'll tell the doc what's going on because sometimes they, like you said, they might see something. Sometimes well, for us, I guess it's more of a set of ears. They might think of something that we're missing. Maybe they understand the situation or they, see it a different way than we do. Because for me, I go by mostly what my patient looks like physically. Versus what the family tells me, because I can have someone like a husband telling me that, no, she's doing fine, but clearly my patient looks like she's short of breath. And sometimes our patients have a hard time sticking up for themselves.
Yeah. Her nose is purple. I don't think she's doing fine.
I'm like, well, she has end-stage lung cancer and she's wheezing audibly and she's obviously having a hard time breathing. So can we give her more morphine, please? It's ordered that way. And you have to really advocate for your patients because sometimes they're too, I don't know if I wouldn't say scared, but they just don't know what it's like to advocate for themselves as much because they've had people speaking for them for so long, which is unfortunate. But we will assess you, based on what your physical appearance is before we look at like numbers, even because numbers are just that they're numbers. But if your pulses or your pulse ox is like 98, but you're having chain soaks, I'm like, well, this is uncomfortable.
So what's man, like I mean, I did like home care clinicals, and you really do feel like you're out there all alone, but you're not. But I mean, you're not. I mean, not. You're a phone call away from somebody, but I think as we found out through this COVID situation where people are distance learning and stuff like that, it can still be pretty lonely to be out there. I mean, a phone call is not the same as being able, like, I can walk over. Well, I can, I can walk out and talk to another nurse and be like, all right, am I completely stupid for thinking this? Is like, what would you do in this situation? And try to give them this. Or go to one of the docs that I trust and have good rapport with. I mean, like, literally just walk to them and be like, have a very low-voiced conversation. Be like, all right, so guys, I think I'm seeing this, like, what do you think? But you're, the level of independence that you have is kind of incredible.
It's kind of, it is kind of crazy because we have to get our whole assessment in, take in everybody's reports from the family to the patients, get everything down on paper. And then one thing I do before I go to a visit is get like the backstory. Because unlike you guys, we're not seeing them for like an acute thing. They've been with us for maybe a month or, we have a whole story on them already. So I have to review if this stuff has already been addressed and maybe they're trying to get me to tweak things a little bit.
Sure.
Or sometimes, sometimes that does happen. They're like, oh, a new nurse, we have to see if maybe we can find something different or whatever. So you have to get the whole entire backstory, look at the case manager's notes. And then we have what I call them, our group of girls. And there are triage girls. They sit in a room in one of our hospice houses and they take our triage calls. So we don't use like a telephone nurse like some hospices do. We have people who used to be case managers who are still out in the field, and they take our triage calls. So sometimes I'll call them and I'll be like, yo, like, I need a second opinion on this. I'll tell the family, I'll be like, okay, I'm going to go call the physician and just kind of talk. And that's what I'll do. I'll call my team. I'll call our physician on call or provider on call and just kind of get like a second opinion, I guess. It's not the same as having someone come in and have eyes on them. But I mean, it's better than nothing. It really, it really is.
Mm-hmm. What's, hopefully it's not on paper anymore, but like, what's charting like for you guys?
Yeah. So I don't think anyone's on paper anymore. When I first started my first hospice job, we were actually on paper.
If you're at the if you're at the VA,
yeah,
like there's still a lot of VA stuff that's on paper.
I don't mind the paper. I almost like it better than the typing. I don't know why.
I think there are. I think because once you're done, and it's like you've got one sheet to do it on, maybe.
Yeah,
I don't know.
And it's just kind of like I don't know. It's just like I guess the computer stuff. People can always find you. Versus charting, it's just like, oh, well, I already left the facility. I can't do any more charting on the patient.
Do you have like a satellite computer, or like how do you do that?
So
do you have to like connect through your phone or something?
We have a hotspot that we use. So if we have like things that we need to upload, we have to connect to the hotspot, connect to our VPN, sync everything. So if I want to order narcotics for my patient, I have to sync my entire system before those orders can go to the pharmacy, then go to my patient. It's kind of a pain. It really is. It's like 5 extra steps.
Do you just have like a pharmacy in the back of your car, like in a locked Pixus in the trunk of your car? Like, how does that work?
So every hospice will have their own set pharmacy. Sometimes they'll actually use the pharmacies that the families have been using, but most of, I think, hospices have one specific pharmacy that delivers meds for them. Okay. So usually on admission.
Oh, okay. So it's not you're going there and you're connecting to your hotspot, VPN, all that kind of stuff, get it all synced up, and you go, I'm going to order some blah, 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 and then you go out to your car and get it. Like, you need to drive to the pharmacy to get it, or
they deliver it.
Or they'll deliver it to the house eventually.
Yeah, usually it's within the day that they deliver it, if not next day. But yeah, we don't carry meds for the reason of safety purposes. So, like, we are not a live network, so we can chart.
So weird. There's less Norco in here than there was before.
Weird. I mean, luckily, we're very lucky to have the pharmacy that we do, and that how they literally deliver 7 days a week. Our DME company is 24/7 as well. So it's very, very helpful in that matter. But the thing is, when you order meds for a patient, somebody has to go back out and educate the family on how to draw medicine up, administer it. So it's a lot of follow-up. And so that also adds to the charting as well. You have to do a note for every single phone call, every single person you've ever touched base with. There has to be a note in there for it. So it's it adds. And on top of that, there's the care plans as well. So, I mean, I don't know how much you guys deal with care plans in the ER. Zero, right? That's what I thought.
Zero, baby.
I mean, it's just a lot.
We deal with other stuff to make up for it, though. So
yeah, that's true. The care plans can be very tedious because not only do you have to, there's so much double charting. I can't even. That's in nursing everywhere. Double charting is everywhere.
Yeah, that's the one of the worst things about the Epic system that we used when I was on a neuro floor was like. Specifically for care plans was like, okay, so you do this and you do this and you chart this here, and then you click accept, and then you go to this other tab where you have to confirm and copy the same thing that you just charted.
Why?
And then you had to import it to the other one and then go back into it was like,
what the heck?
What? Dudes, come on. It's like, guy.
You know, people who do these charting systems. I mean, I have to say, we use NetSmart at my job.
Sure.
On top of the first digital or the first live charting system I used was from my previous hospice. They made their own. They didn't buy one. And I have to say that was actually, it was very user friendly and it was live. We could fax things from our little iPads.
Oh.
Everything was live. So it was just like connected right away when somebody uploaded something. It was very, very user friendly. And the whole charting system was geared all towards hospice too, specifically, like
versus you're trying to make
home
something
care or something. Yeah.
Versus you're trying to make med-surg charting system work for a hospice situation.
Right. In that system they had it was a patient predictive score versus, so the higher it went, the more likely they're going to need a visit overnight or they're going to need follow-up. So if a patient was in the red, that means they're either transitioning, active, or they have an issue. So it kind of triggered the system to alert us that, we're going to need follow-up. So it was very, very user friendly. I mean, not that this one's not. I think the fact that it's not live really kind of hinders us and is a pain in the butt when you don't have reception in the middle of nowhere. Right. You can't upload anything, so you have to drive somewhere else to upload it. I'm like, what are we doing in 2020?
So if I'm just talking about like a single family or something like that, are you the only nurse who is serving that family?
No, so I work primarily on weekends. I'm like, okay. I call myself, like, on the weekends, us nurses are like the ER of hospice. We are fly by the seat of our pants, literally go wherever we're called to, seeing for PRN issues or like patients who do need follow-up. But even if a patient does have like one a case manager, they're supposed to have one, they will see other nurses in between that to supplement the team, as well as everybody else that is on the team. It's a lot of people.
So you've got to be a lot more flexible than like if you're the weekday are like the weekday nurse,
weekday people.
Like the weekday, like I feel like your relationship with the weekday hospice nurses is like
we're night shift, they're day shift people.
Day walkers.
Yeah.
They're just like people are like sunshine, like so you take care of, because you're kind of weekend, you're taking care of acute exacerbations of chronic conditions kind of things, and so you're a little bit more like, how does that work out?
Like we do like pain crisis issues, people having respiratory issues. We also do, so the case managers will put in on Friday if anyone needs visits over the weekend. So we will go and see patients who are transitioning or active just to make sure they're comfortable. We also go do wound care. Like our patients utilize CAD pumps. So a lot of the times on weekends, I'm changing cassettes for CAD pumps, giving new meds in, things like that. And sometimes even we have a lot of patients in assisted livings, which they require a lot of attention because of the fact that, I mean, they do have nurses there and they're skilled nurses. They just, because of the nature of the beast.
But there's one and there's 150 residents.
And they can't, because of the nature of the beast, their scope of practice is limited.
Very limited.
I mean, their scope of practice is what it is for their license, but I would have to say it's more of the policy that limits their scope of practice.
I'll buy that. Buy that. Yeah.
Because they can't necessarily take a temperature or a blood sugar or things like that because it's an assisted living, but they admit patients that are not assisted. That's just a whole nother thing. So we have to go there. Like if a patient falls, even without injury, we have to do a visit.
Yep.
And that's a whole nother slew of charting. We have to put a whole nother note in, and it's that's kind of, I mean, I understand why they have to call, and it's better for me to go there than having them have to send them out, which is like more so their policy.
Which is what happens to us.
You guys get a lot of the falls.
Yep. I get a lot of them. Well, let's take another quick break. We've been going for about, I think, 20 minutes or something like that, which is perfect. That's okay. It's exactly perfect. So when we come back, we'll kind of finish up on this attributes and other things about hospice nursing, and then we're gonna start with bad and kind of not end, but we'll transition to a good thing. Let's talk about maybe some bad experiences that you've had, and maybe some other things going on between your nursing school experience and maybe your work experience, and then we'll just see where it goes from there. Okay, so let's take a quick break, and we'll come right back.
Nick's Horseless Diner. Nick's Horseless Diner has one single promise it makes to you and to every patron who enters that big green awning. Delicious food at a reasonable price in a fun atmosphere with absolutely no horses whatsoever. Horses are not only not allowed in the diner, they are certainly not used by the kitchen or waitstaff. No donkeys, no mules, and certainly, without question, no horses. The management of Nick's Horseless Diner is so opposed to the concept of horses crossing the threshold of eateries that it refused service to jockeys until 2014 when required to by federal court order. Yes, sirree, come to Nick's Horseless Diner for good food, good times, and a palpable dearth of ponies. Nick's Horseless Diner, no horses, ever. Okay. If you're new to the program, that was probably a slightly confusing advertisement for Nick's Horseless Diner. To put that in context for you, last week our sponsor was Snuffy's, which is a diner off Route 44 where the waitstaff rides horses. That's their thing. All the waiters and waitresses are on horses when they take your order or when they deliver it to you. So it would appear, and this is sheer speculation on my part, but it would appear that Nick's is mounting some kind of very aggressive ad campaign aimed at the selling point that they don't have horses, which is odd in that I just sort of assume that you don't have horses to begin. You don't need to tell me your diner doesn't have horses. I would never think that your restaurant had horses involved in food preparation. I mean, like, I've never driven up to an Arby's before and gone, hey, I'm thinking about going in with my folks, but I wanted to confirm there are no horses inside beforehand. No one does that. So that's kind of strange. The thing that, now that I'm thinking about it, the thing that's even weirder about that is the name of the business is Nick's Horseless Diner. So it's not just a transient marketing campaign. They're actually, they appear to have started a business model based on not having horses, which I don't even know what that's about. I should point out that we still maintain a good relationship with Snuffy's. In fact, you can now buy Snuffy's T-shirts. We do have some Snuffy's merchandise. I've not been to Nick's yet, but I'm planning to go later tonight to enjoy their fine atmosphere with its lack of horses and good food. So more on that later. Nick's Horseless Diner, no horses ever.
To hear more from Andrew Heaton, you can search him out on basically every platform there is out there by searching for @MightyHeaton. That's Heaton, Mighty Heaton. Let's get back to the show. Okay, so welcome back. Kind of tell me, let's talk about some nursing school experiences that may stand out to you. Like I mean, it's a nursing school podcast, so we got to talk about nursing school on some level here. So can you talk about like a bad nursing school experience that kind of stands out to you?
Okay. I think
pick a card, any
all
card.
Of them, med-surg was probably the hardest and most difficult rotation you go through because it's like a smorgasbord. And of course, for my med-surg, my first rotation through it, I had one of our like toughest teachers. she was so nice by the end of everything, but at the beginning she really was like hard. So when you would mess up, what she would do is she would be like, all right, I'm going to walk away and let you think about that. And then you're sitting there at like your cow or wow or whatever they call them, either one, depending on.
That's a computer on wheels. You're not talking about like a fat patient.
So I think a lot of hospitals don't call them cows anymore, right? They call them wows.
Yeah, like when you pass a patient, we're like, go get the cow, and the largish patient, like gets offended and calls the patient comment line or something like that, and be like, they called me a cow.
The wow.
No, probably referring to the computer.
So she would leave you there and let you think about what you just said if it was wrong. So I think it was like heparin. One of our patients was getting heparin injection, and she's like, where would you put that? I'm like, she's like, I'm going to walk away and let you think about that for a second. I'm like, don't do that. Like, you're my teacher. Just tell me where to put it. I figured it out.
I have my cell phone, so I'm just going to look it up real quick.
We didn't have our phones. I don't know how I figured it out. I either looked in my drug book or I was looking at the MAR, and it may have said somewhere along the lines of where to put it. But sure. I think when we also did a rotation, my other med-surg rotation was at an older hospital where they still, in the supply plaza, they still had the burners from when nurses used to cook the meals. That it was like, I know.
Fantastic.
I was like, my patients would have got mac and cheese and cereal because I wouldn't have taken that much time. So what happened was I had this old man, and luckily I had a different teacher this time. So he was a guy. He was a naval nurse for a while. And so we were doing meds. And of course, the Colace comes in those little packets, which are awful. So I didn't know, because it was like, you don't know how Colace is going to behave. I should have just cut it open and whatever, but I was trying to be a good little duder and peel it. So, and then I was trying to pop it, and then it popped across the room. Pew! Yeah, it was like a little missile. And I was like, well, I'm going to have to pull another one. So, yeah. And then when I had to stay after school to practice.
See, that's the difference. That's the difference between med-surg and ER. I'm gonna go pick it up and be like, just.
Do you guys give Colace in the ER?
No.
I was like, what?
No.
Like, no, probably not. Yeah. Yeah.
Probably
and then I think one of the other worst things was having to learn hospital corners on the beds. There was like a group. I know there was a handful of us who had to literally stay after because we didn't make our hospital corners good enough.
And I grew up making them, so that was like no big deal. And no big deal to me. My grandma was a Navy nurse, so we had to have our beds made that way. Plus, I spent a decade in the military, and you go off to a school and you get issued all this stuff. So like that was like an easy part of.
I mean, usually I didn't even I didn't realize
some of
that
those
was
things.
A thing, really. I mean, my sister is also a nurse, but she never mentioned that because she was a NICU nurse. So guess how many times she's done hospital corners? 0. Bye-bye. So, and I've never really done hospital corners since then, to be honest with you.
Oh, yeah, it's like taking a manual blood pressure. Like, I
do that often, actually. I prefer it.
Well, I know, but I don't have to. So it's like, I mean, I can do it. I can still do it. And I'm like, I've had to do it a couple of times just because, like, you get those patients just have, like, I had a patient probably not even a month ago. Actually, probably about, a month ago. Let's say 2 months ago. I don't know. It all runs together right now. Like this whole COVID thing's like, I was at work so much that it was just like, I can't tell the difference between day and night and weeks. And so I think about 2 months ago, like this patient was like, oh my God, did I even go to nursing school? Like, how do I not know how to take a blood pressure? I was a freaking EMT before this. Like, I should know how to do jaw thrusts. Bagging patients and blood pressure. Like, it's the only thing that I know how to do. Like, that's like, I should know those 3 things, and like could not get it. and I brought like another nurse in who is like a paramedic in a previous life, and she's like, I cannot get a blood pressure off of this person, and we both did manuals, and I was like,
So
okay, I think we're gonna move them into a
what was
critical
the
care
blood pressure?
room.
Must have been super low. You can't palpate it.
I think we got either we only got systolic or we only got diastolic. I can't remember, but it was so over the place. It was so inconsistent. We just couldn't nail anything down. It was crazy.
I use an electric one. I have an electronic one for some of my patients, because especially for dementia, I have one for the wrist, because some of them are fairly smaller people too. And I mean, you put an arm cuff on some of the people, they're going to try and fight you back. It's a kind of a big thing. And they're always wearing 12 sweaters. So I'm like, I'm not going to have them undress for me to do a blood pressure. Just give me your wrist. It'll be fine. Some of them, the wrist cuff doesn't work for them because it's not, their wrist isn't the appropriate size, but yeah.
Oh man. So so tell me about a good nursing school experience or a good nursing experience, either one that kind of stands out.
Especially in nursing school, when I had my first hospice patient, that was a good one. Yes. But in working in hospice, they're relatively all good experiences, because people are just so, I don't know, it's just such a delicate time in their life. I think it's really hard for them to be, their emotions do run high sometimes, but usually it's never towards the nursing staff. It's actually really nice because you get to feel appreciated, versus I feel like in a lot of other fields, nurses feel really underappreciated. You know what I mean? A lot of times people, like when we go in, people are like, every time I hear anyone who has ever had any experience with hospice, the first thing they say is, I love my hospice nurses. I love my hospice aides. The hospice team was amazing. We get so much wonderful feedback from people, and that's just such a lovely thing to hear. And they let you into their homes and their lives, and kind of get to be a part of that for a little bit. Even though the weekend crew never gets any like, hey, remember that nurse on the weekend? It's always usually like the main care team that gets the
you're like the weekend and part-time, or the holiday
we're
male
like the
person.
Bastard child of the hospice family. We just don't, we kind of sit on the side. We're like, well, we don't mind helping. We don't really want the whole heroic measure thing anyway. We kind of just like being able to go in, go out, and do our stuff. And and it's really lovely to meet all of these fantastic, I've met so many, what I would say they're famous people, but they're not famous like celebrity famous. Like they've made significant changes to things that we use every day in our lives. Like they've invented them, like holding hands that are 102 years old. That's amazing.
Yeah.
To think of that. You know what I mean? It's just crazy. I had one lady, she turned 101, and her daughter was like, I'm not getting you another cake, because she got a big thing for her 100th birthday. She's like, well, can I just have a slice of cake then? I was like, she was adorable. So
I remember like in my own experience with a hospice nurse, I'll go back to when my grandma Smith was dying, and oh my God, my grandma, she's like, she looks over at me, and I took, like, I was in the military at the time, so I took like 2 weeks of leave, which is an insane amount of time to take off. So I took like 2 weeks, because my family called me and they're like, Grandma's gonna go. We're like, okay. So I drove all the way home, which was like 900 miles or 1,000 miles or something like that. Took me quite a bit of time to get over there, and got there. And on, I think the second day, Grandma opened up her eyes and looked at me, and she goes, you know what I want? I was like, what's that, Grandma? What do you want? Scotch.
Yes.
And the hospice nurse was there.
She said, right?
and no, it was the exact opposite. No, I wish you guys could see the face that Nurse Allie just gave me. It was just like, what do you mean no? But the hospice nurse goes, no, she's on a morphine neb. She can't have. I was like, oh, are you kidding me? Of course, I'm not a nurse at the time, but I'm not a nurse at the time, but it was like, are you joking?
Yeah.
Like, Grandma wants scotch in the rocks. Grandma's gonna get scotch in the rocks.
I'm not gonna say.
Grandma, what do you want? Do you want the 12-year-old Glenfiddich or the 15-year-old Glenfiddich? Like, what do you want there?
If that's what she asked for, just chart it. Just chart that you educated on the, that it contraindicates morphine and the possible side effects of it, but also chart that, that she had. It's okay. I mean, if I can't say it's okay legally. I can't say it, but am I gonna tell my patient no, that they can't have something? I mean, they've asked me before.
No.
But I'm like, that in some skilled nursing facilities, they still have like whiskey and wine on their med carts as something that patients will have as a medication before they go to sleep instead of sleeping pills. Sure. I think it's okay. I think if that's what if my diabetic patient is nearing the corner and they ask me, like, I just really want something sweet, you know what I mean? Like, what? Just don't do it in front of me, please.
Would you like a butterscotch?
Something. I can't say no. I'm like, that's why we encourage pleasure eating, because their taste buds can change, and why not? What is going to happen if she has a scotch, really?
The 56-pound old lady, she wants a cheeseburger. Grandma's going to get a cheeseburger.
Really? If that's their wish,
I'm going to get Grandma a cheeseburger.
If that's their wish, why not? We do it to inmates on death row. Why shouldn't our hospice patients, especially our hospice patients, should get whatever the heck that they want? I don't even care.
I agree. I can't tell you how many times I had to like move Grandma between her bed and like the chair so she could watch her birds out the window, like moving her back and forth.
Little
and stuff like that. No.
I swear, they just love it. Like that's their thing, and if that's what they want to do, like some people, everyone has their thing, and God bless them. Honestly, more power to them. If that's me and I'm in that kind of position, just get me a glass of wine. I'll be fine. We're not afraid of them getting addicted to the morphine. We're not afraid of them having a little glass of wine at that point. That's a huge problem. People are afraid their loved one's going to get addicted, so sometimes they withhold it.
You know what's really funny is, so my grandma was a nurse, and she was a Navy nurse, and the hospital corner grandma. So, but we had. Oh God, like that was one of at the end of her career, or at the end of her I should say at the end of her working day, she worked at a rehab facility, to help kind of people transition and deal with withdrawal and all that kind of stuff. Okay. And she so like people would go, and it was like an inpatient facility for people who are going through like trying to get dry, or whether it was from street drugs or from alcohol or whatever. But she would do, so she was like a nurse counselor or whatever it was. So she kept her license going for a really long time, and she was probably in her I want to say she was almost 80 when she let it go. Yeah, she was almost 80, I think, when she let it go. So she was a nurse for 65 plus years. So where did she get her?
Because I know her generation, typically, they were more so diploma nurses, right? Was she a diploma nurse, or did she?
She was, she was a diploma nurse, and
They're very well clinically trained. I have to say, very hands-on trained.
Grandma did her, so she, before, when you had boards, so she took the boards from the state that she was living in at the time, and then and then she had and then the toughest nursing board in the United States at the time was New York, and so her father paid for her to go to New York to go take those boards. So because everybody recognized New York at the time. So Yeah, so because it was the hardest one at the time, and then she took the test, took the train all the way back home, however many hours that took, and then had to wait like 8 weeks to see if she got her license or whatever. Like, right. So she's on hospice. The hospice nurse comes in or whatever, and I was there for the first dose of neb morphine that she ever got.
I've never used that before.
And yeah, it was
I've heard of it.
That was some kind. I think it was like neb morphine. So she'd put it in, or they put it into the nebulizer, and she'd breathe it in, and whatever.
Did you get any residual effects from being around her?
No, I stayed out of the room. I was like, there's no way I'm gonna like risk my military career to get a contact high.
Yeah, right. Exactly.
But they had, this was a woman who, like, warned other people about the addictiveness of drugs and all that kind of stuff, and I remember that first breath that she took on that neb, and she's like,
yeah, it's funny stuff.
I was like, oh grandma, yeah. Like, but
good old morphine.
So let's go back to orientation. Well, actually, let's take a pause real quick. And then when we come back, we'll take a quick pause, and then when we come back, let's do like a little bit of orientation discussion and stuff like that, and then we'll kind of just ad-lib and see where the show takes us from there, okay? Sponsoring this segment of the Real Talk School of Nursing podcast is Mike and Bonnie's Snow Shovel and Driveway Salt Emporium. When the temperature drops fast and rain turns to ice in your driveway, which is then covered by 6 inches of snow, you need 2 things: snow shovels and driveway salt. Luckily, there's one place you can get both of those things. They have everything. They have all of your favorite trenchers, cleanouts, border spades, cap rocks, post hole diggers, grain scoops, and hand trowels. That's right. Everyone from the toddler in a sandbox to the fashionable urbanite and the sun-hardened farmer. Mike and Bonnie's Snow Shovel and Driveway Salt Emporium can cover all of your scooping, transferring, farming, digging, and shoveling needs. So, stop by Mike and Bonnie's Snow Shovel and Driveway Salt Emporium off Route 44, where the only thing that's deeper than the holes you can dig with their great shovels is their discounts. Bring your receipt from Nick's Horseless Diner and get an extra 5% off of your purchase. Oh, wait, this just in from Snuffy's, where all the food is served by waiters and waitresses on horseback, that if you bring your hoofprint marked placemats, you can get an extra 10% off of your purchase. I asked if this was in addition to the 10% you get off for being a Real Talk School of Nursing podcast listener, and all I got in response was... I'm not entirely sure what that means, so let's get back to the show. So let's talk about your orientation, because you could probably say you had like 2 orientations. I mean, because you had two very different jobs as a nurse, right? So you started off prison nursing, which is probably not the first job that people think of when they're, a new grad or they're in their last year of nursing. They're like, I think I'd like to be a nurse in a prison.
Yeah, correctional nurse. Why not?
People don't think of that. And then your second job is probably the second least likely thing that somebody is going to think about when they're in their last year of nursing school. It's like, you know what? I think I want to go into hospice nursing. I don't see that as a very common thing.
Unless you've had an experience with hospice, right? Unless you not come up,
right?
Yeah.
Everybody's thinking about like, well, what kind of med surg unit I want to be on, or
everyone thinks hospital.
Everybody thinks hospital.
Everything's hospital.
Yeah, everything's hospital. Yeah. Everything's med surg, ICU, ER. Whatever you want to do. So tell me about orientation, because orientation is a really tough time in a young nurse's life. And it doesn't matter if you are, in your upper 30s like I am, or if you're 23 like the 3 or 4 nurses that were in my hiring cohort. We all struggled. And whether it was because of how busy we were or how much we had to learn in such a short amount of time, like what was your orientation like? And you can talk about either or mix them in or whatever, but like what was orientation like for you?
For the prison, it was a little different. You got, oriented to being inside the prison first. They're going to obviously go over safety with you, what not to bring in. Like we couldn't bring in soda cans and things like that. No bobby pins, obviously.
Huh.
Nothing metal.
I wouldn't have thought of that given my...
Yeah. No, you can't bring in your own stethoscopes either unless they're approved by the soup. So and we obviously don't hang stethoscopes from our necks because they are a asphyxiation hazard.
Interesting.
Yeah, it was not that typical, like I'm going to rush into a trauma scene nurse where you have your stethoscope and all of this stuff. And nope, no running in prison either. We don't do that. So you get associated with the prison, how to kind of go about your job safely. And then you get put into the actual prison and you get paired up with like another nurse, whether that be an LPN or an RN, whoever is free to kind of orient you that day. And you get I think it was about like 2 weeks of shadowing somebody. And then you kind of just go, you're not really on your own. You always have somebody like near you. So that's was kind of nice about it. We didn't really have to go through too much desk work. The most desk like work stuff that we had to do was the prison part of it.
Sure.
The nursing part was very, very hands-on. You know what I mean? Not too much behind the computer training at all for the nursing part. Versus like hospice, it's a little bit different. You do have to do a lot of the behind the computer stuff first, get all your courses in, get oriented to the system, and then you get to go out with somebody and start kind of doing visits. And you get to also, in my first hospice job, we got to go out with multiple disciplines. So you kind of got to see how the chaplains were, the social workers, different parts of the team, and how they everybody kind of links up in the care team. And then you had, of course, your orient. I was able to shadow a wonderful, wonderful hospice nurse. I mean, she was like the main one who kind of taught me everything I know. And she was just wonderful. Yeah, she was, the thing is, she was around, is she younger than me? Now I can't remember. I think she was around my age, but she had been a nurse for longer because she actually graduated high school early. So she got her associates in nursing, and she was a nurse by like, what was it, 19 or 19 years old or something like that. So she had been a nurse for a while, and she was just wonderful. And we had a bunch of really experienced hospice nurses on board too. So you got to go into IDG meeting, which is a super big thing or IDT. Some people call it IDT, which is the meeting of all the disciplines. Every 2 weeks everyone links up and kind of does a review of each patient, and you just go through the list. I was never a part of that because I always did PRN visits. So like they would order lunch and things like that for IDT, and I'm like out in the field like eating my Uncrustable sandwich. Yeah. So it's like it's fine.
Sounds like me in the ER is like it's I get ice chips and beef jerky. It's like dinner 3 nights a week at least.
Yeah. Beef jerky. I used to eat that a lot, except now with because I just don't want to like touch my mouth so much, like flossing wise and stuff. So I'm like, it gets all up in your teeth. So yeah, hospice I think was back to orientation. I think hospice
it's like a variety show here.
I mean, you get your beef jerky, and one time I actually did wound care on somebody, and I went it was a coccyx, but it was like literally I could go into my wrist deep into this wound, into this pressure ulcer. And I was just charting in my car after eating beef jerky. I was starving.
It reminds me of the post I made a couple of days ago. I was like, nursing is the most beautiful
that
and
guy.
gross thing.
Gross thing. Gosh.
Every time I watch that, it's funnier every single time I watch that. But it's like,
well, it's like, there is cool things, but they're gross at the same time. Like, you just can't talk about certain things over meals with certain people that the way you can with like people who are in the medical field. You just can't.
Totally.
Because they're just like, well, now I can't look at my spaghetti sauce the same.
Like there's this, I don't remember what the show was. But it was like this old kind of crazy guy. It's the same guy who played like the steward of Gondor in the Lord of the Rings movies.
Oh,
that
really?
guy, yeah, he was like this old scientist guy or whatever. But I remember this one scene in one of the episodes. Very descriptive. I'm sure everybody will know exactly what I'm talking about. But he's
this one scene in that episode.
Yeah,
yes.
But he's like this old kind of sciencey guy, and he's literally got like this. He's doing an autopsy on this body, and it's totally flayed open, and it's like, I mean, from stem to stern, it's totally flayed open, and he's got like a packet of Twizzlers sitting on top, and he's just eating them.
It looks like, I mean, we watched one not like an actual one, but a recorded autopsy in school.
Sure.
And it's literally like trying to get under the hood of the car. Like they crunch. Oh, yeah. I mean, I don't want to, well, nurses are listening to this, but it really,
you'll be fine.
It's like, and the cuts are like so perfect, and they just flip open the rib cage like the hood of a car. They're like, whoop, all right, like, let's look in. Yeah, so stuff like that you need to. Yeah, but what were you talking about? Orientation. Yeah,
it's the variety show. It's the variety show section of our show.
The thing about orienting with hospice too is you may not get all of your experiences in while you orient. So you might not ever get to see a patient who, you might not, like my first job, it was a little bit smaller of a hospice. So like I never really got to have hands-on experience when somebody who was actively dying when I had those 2 weeks, because it just didn't happen. Mm-hmm. Did I have to do it on my own at one point? Absolutely. So, it happens, but I had the nurse, the case manager, she's like, do you want me to come out there? I was like, no, you need to let me fly. Just tell me what to
do. But I think there's something to that. There's a bunch of memes out there that it's like, growing up, I really thought that quicksand was going to be a bigger deal in my life, like a bigger problem in everybody's life, but, and like, I think through orientation, we had a pretty, compared to other places. So I know of hospitals around the country that have like a year-long orientation in an emergency department. Right. Again, I wish you could see her face when I say that.
Exhausting.
I would die. It'd be like, okay, it's been 8 months. Leave me alone.
Am I off probation yet, officer?
Well, and some, I don't know exactly how they run it, obviously, but like some of it might just be like you have a dedicated person that you go to. You're still independently doing stuff after whatever. But I think I had 40 shifts, and guess how many NG tubes I did in those 40 shifts? Pow, goose egg, 0.
Right.
Like 0.
Right.
And like how many NG tubes have I done in the last 3 weeks? Like probably 5, 6, 7, 8, something like that. Like in the last 2 weeks, It was like you're gonna have things that you're never gonna experience in orientation that all of a sudden be like, wow, I really haven't done this since skills checkout in nursing school 4 years ago.
YouTube.
Yeah. No, literally, like I have done the stereotypical, like I'm in the supply room, like checking out YouTube or Googling something.
They
like,
have helpful videos on YouTube.
How do I do this again? I forget.
Especially for hospice, one thing that has happened is like we do have quite a few patients with those CAD pumps that I mentioned earlier, which is just a subcutaneous button that administers med through a little, I don't know, looks like one of our old Nintendo game. And so we Anyway, I love those. Now I want one. And so some nurses will need a retraining on them because they haven't even, they might not have had one in 6 months. And then you look at it and you're like, what the am I supposed to do with this thing? So actually in my current hospice, we have a couple of girls, and I think maybe a guy or two nurses who are deemed nurse educators. So if you need to review a skill, they're there for you, and you can get in-person training, or now we're doing, the
Zoom,
the FaceTime.
Yeah, Zoom, FaceTime, whatever.
Yeah. So they'll be there to kind of help you out if you need to review a skill. But if you don't know a skill, I think the first thing you got to do is admit you don't know how to do it. If you're really, really unsure,
Man,
I
think that is
hard.
like, I think of if
Mice
there's
and men.
Well, yes, also that, but I think that's one of the big things that came out of orientation is that number one, nursing is a team sport. Like you have to have the confidence to say I don't know. The confidence to ask for help is, like, I think the quintessential thing that you have to learn in orientation. The confidence to say I'm not sure. I need to ask for help, and then to kind of to add on to that, to ride the coattails of that is knowing who to trust, knowing who you can call, and because I'm sure
not Ghostbusters.
I'm like, stop distracting me from my thought process. I have not gone to sleep yet. It is like it's 4:30 in the afternoon, and I got home from work. I recorded like 2 other podcast episode thingies, got my kids off to school, and then I still haven't gotten to sleep yet. So I'm very distractible right now.
You did a lot of adult things. I am so proud of you.
I did some adult things. I even cooked breakfast.
Is it cereal?
No, I'm like healthy and stuff.
Yes, okay.
Today, and or at least this morning, but like knowing who to trust. Like I'm sure there are people within your group or whatever be like, I'm definitely going to call this person for this issue if I need help.
That's one thing. I trust everybody. That's one thing, is that there's not that, I don't feel hostility between me and other nurses in hospice.
I don't either. Like, even
not necessarily hostility, but like sometimes you will get, like, I can say in the prison there were people that I was a little more intimidated by, that I didn't feel comfortable asking necessarily for help. But in hospice, it's just like everybody just is so helpful. It's almost just like, I don't know,
a team
what's
sport.
wrong. It is. I mean, we have the IDT. That is like our thing. We're an interdisciplinary team. So I guess that's kind of, we all have to work together for the patient's main goal, versus I think sometimes, like I've even encountered, even on social media, like reading in the comments, you see nurses who just don't seem like team players. And I think that's more important for the quote unquote veteran nurses, or the nurses who are working now, is be open to like teaching, because that's what you're there for. It's not cool to intimidate a new grad. It's not cool to intimidate a new hire. That doesn't make you a better nurse. That's the complete opposite of what nursing is about.
I agree.
So we have to be open both ways, open to asking the questions and open to answering the questions, so that everybody can get what we need to get done.
Do you think so? Like, one of the things that kind of comes out, I think, in orientation is, I think new grads can sometimes get not confused, but get mixed up between being under pressure and being bullied, because for example, like I felt like I knew the difference. Because there was one of my preceptors, like, several times set me up for failure, and I was just like, what the flying rhino is this? And and then there was a couple of times where I was just like, okay, I'm just under a lot of pressure right now because there's a lot to do, and like I have a lot to learn in a very short amount of time, and I have to take advantage of these learning opportunities. That this might be the only time I have to experience this with someone to watch over me to a certain extent, and I don't want to, I don't want to not ruin that opportunity, but I don't want to waste that opportunity, because it can be very difficult to, I guess I would rather go through that pressure and have somebody be near overwhelming with somebody,
just to make sure.
Right, exactly. So it's like I'd rather be near being overwhelmed with somebody to help watch over me at one point or another than
I think that should be something that happens everywhere.
Then have to like deal with this 6 months down the road when I haven't experienced it yet, and it's like a like a 3-way Foley, and I have to insert this 3-way Foley in this patient or whatever. And it's like I haven't done a Foley at all since I got here. Suddenly I have to do like the hardest one there is.
Right.
24 French. Woo!
I mean, oh my God. I think that I think that we should all around, like, I know in hospice, before we do a new skill, we actually will have a nurse educator meet the nurse, or, out in the field, and do the skill with them out in the field before they're allowed to do it on their own. So that's how, I think that's how it should. I mean, if it's a new skill, if you've really never approached it before, like we have patients who have pleuric strains, we have patients who have all sorts of things. And not every new grad is going to have those skills. So I would rather have them be confident. And like I said, we can always call them if we need a review of the skill. But I feel like everywhere they should do stuff like that, because it makes you more confident, because you don't want to be doing a skill all by yourself in a house that you've never done before, and like
tell me if you feel this way, but I feel like sometimes our system is a little bit reversed, where I feel like in nursing homes, it's the new grads, it's the brand new LPNs, the brand new RNs who end up going and taking care of the most complex patients that we have. And then, polypharmacy, and they're at the end of life, and all of these issues that are just more
complex.
Right. Are,
and it's a high patient load as well.
Right.
It's a lot.
It's a lot for them to go.
It's a lot. I mean, and I ran into a new nurse the other day at a skilled facility. He was getting oriented, but he was starting to do his own med pass. And I mean, he had a smile on his face, but even them going into jobs right now, imagine that, like being in a COVID world, your first job is like, this is a whole new ball game that they're approaching as nurses. And I think it's 10 times harder. And all those new grads are going into places where they need a little bit more skills. But what's nice about the nursing facilities or the skilled facilities is, like, even working in the hospital, you do have a buddy around. The problem with skill facilities, though, like everywhere else, is that everyone's super busy. So it's like, I still learn things every day, and there's always a new skill to learn. Always. There's always a way you never thought of doing something that somebody shows you how to do something.
And I think, like, at your level of nursing after 7 years, you probably were like, I learn something new every day. And for a new grad nurse, it'd be like, I learn 75,000 new things every single day. And I think that's okay. And I think you should give yourself a little bit of grace if you are... You got to give yourself a little bit of grace if you're a new grad.
It's a totally new environment. It's hard, and it's going to be hard, and it's okay to have hard days and have bad days. I still have had bad days. I oriented at the hospice house for the first time. That was probably one of the worst days of my career, and that was last year.
So that's where we're going to end. Let's I think we should try to get together again if we can. I would love that, and of course, follow Nurse Allie at.
You can just look up Nurse Allie.
What's your Instagram page again?
Nurse.
Love it. Let's look for our future arguments on Instagram in the future, and
hashtag bring back the capes.
Oh my God. Hashtag no more capes. No capes.
Hashtag yes capes. Hashtag
I can't even do my own
capes.
hashtag, right?
The great
hashtag no capes.
Thanks for having me.
All right. Love you, Nurse Allie. Thank you so much for joining me.
Bye.
Are you tired of the same old badge reel? Do you have to wear the same scrub color as everyone else? Are your undershirts boring and kind of stinky after wearing your lucky shirt through 5 in a row 12s? You can wear your personality in other ways. Go to badgeladybynerdwear.com and check out her massive selection. Tell her you're a Real Talk School of Nursing podcast listener and use the promo code REALTALK20 at checkout for 20% off your order. Expect 2 to 3 weeks for custom orders and a few days depending on her actual job schedule, because she's a real nurse, to get your badges made and shipped. I know you'll treat her like your best friend at clinicals, so go to badgeladybynerdwear.com and order the coolest custom and original badge reels out there. Go to badgeladybynerdwear.com and use the promo code REALTALK20 for 20% off your order. That's badgeladybynerdwear.com and use the promo code REALTALK20 for 20% off your order. This Real Talk School of Nursing podcast is a Real Talk production. This podcast is dedicated to our brothers and sisters on the front lines of this COVID-19 situation.
Sic semper tyrannis, facta non verba.
Good night, Steve Cannon. Wherever you are. Annyeong kasayo. Now you go home. Thanks for listening. You can support the show directly on our Patreon account at www.patreon.com/realtalknursing and gain benefits such as early content, shoutouts, and special swag. Write into the show at realtalknursing@gmail.com or use Facebook, Twitter, or Instagram at realtalknursing. Thank you for supporting our friends, affiliates, and sponsors and following us all on social media. More listeners, likes, and followers means more and better shows. Make sure to share the episode with classmates and give a hand up to those who are coming behind us. Don't forget to reach out and tell us if you have any announcements or special shout-outs to friends, classmates, or colleagues. If you like the show, the Real Talk School of Nursing podcast is available everywhere, so go to wherever you download podcasts, subscribe, rate us, review us, write into the show, and smash that subscribe button. Remember to leave only 5-star reviews, because that's the only ratings that count to get us noticed by more nursing students. We want you to be part of this crazy nursing school journey. The Real Talk School of Nursing podcast is a holy moly, I can't believe you're still listening to this podcast.